Thank you for a kind introduction, and I would like to say thank you to Dr. Kashdin for inviting me in this beautiful conference, and which is held in this beautiful city. And, as you already shown in the previous presentations, ICG is commonly used to help our surgery. I would like to summary about the several studies regarding ICG fluorescence imaging and our experience. I'm from Daegu in Korea, and this is our city. And our city is also very famous for the hottest summer in Korea, so we can make fried egg on the road very quickly. And this statue is located in the mountain, which is nearby our hospital. And we have two hospitals. The lower one is our original hospital, and this is a new one. I'm working here with Professor Chen, Professor Park, and other my colleague. And during the conventional surgery, we can see the inside of the layers after we peeling the layers. And sometimes it's ambiguous or difficult to discriminate the condition of the organs. So currently there are many imaging tools we can use preoperatively or intraoperatively. Preoperative imaging can show many informations about patient's body, but we have to reconstruct the image during our surgery. On the other hand, intraoperative imaging can help us on site, and fluorescence imaging is one of the most commonly used one. As you know, ICG and IR imaging, in ICG imaging, fluorophore and NIR light is the important factor. So this image show how ICG image can show the organs inside of our body. So ICG fluorescence imaging now currently used in various operations for solid organ, breast cancer or hepatic surgery or head and neck, and as well as colorectal surgery. In colorectal surgery, ICG can be used for such a seeing the perfusion or lymph node metastasis or peritoneal metastasis. So there are four big categories for using ICG imaging: perfusion, lymphatics, and localization and metastasis. Previous presenters already show about the localization during the robotic surgery, and perfusion also some presenters showed. I will discuss about perfusion and lymphatics. First is perfusion. When we perform colorectal resection, marginal artery is important to preserve the perfusion to the remnant colon or rectum. But sometimes there are variations in the marginal artery and anatomical variation, or sometimes we can make injury to marginal artery during our surgery. So the confirmation of the perfusion is important important for safe after colorectal resection. This was performed 2 years ago by myself, and he had a history of abdominal aneurysm surgery. And I performed IMA ligation, and until the anastomosis, I didn't know about the perfusion problem, but after waiting several minutes, there were slow change of the bowel color to purple, more and more after passing time. So at that time, I didn't use the ICG, but I decided to perform additional resection, and then redo anastomosis, and the perfusion was good after that, and patient discharge it without any problem. So currently I use not for all patients, but for some patient with a medical problem or some when I am considering about the perfusion problem. I usually use 5 milligram ICG IV, and after 40 minutes we can see small bowel perfusion, and after about 1 minute we can see the vascular structures on the mesocolon, and 10 seconds later we can see the colon perfusion. And in this case there was no problem in the remnant sigmoid colon perfusion, and anastomosis was safely performed. So there have been several studies about the perfusion check by ICG, and until several years ago there were 3 big randomized controlled trials, and 2 of them could not show the difference on the anastomotic leakage rate. But FLAG trial, which evaluated the safety of colorectal anastomosis using ICG, and they could show the improvement in to reduce anastomotic leak rate from 16% to 9%. And in this meta-analysis, we can also see the effect of ICG fluorescence imaging to check the perfusion and can decrease anastomotic leak rate. And recently there have been 2 big trial results were published, and essential trial was performed in Japan, and they evaluated more than 800 patients who had rectal cancer, and patients were randomized to conventional and fluorescence imaging guided group, and they used the fixed dose of ICG, 12.5 milligram, and leak rate was reduced from 11.8% in the conventional group to 7.5% in ICG group. This year, AVOID trial showed their result, and they evaluated about 10,000 patients, and they used ICG fluorescence imaging for colon as well as rectal cancer surgery. And in the overall patients, there was no difference in leak rate, and they used 5 milligram ICG, and then they divided the patient to subgroup: left hemicolectomy, sigmoid, and low anterior resection. The most difference was found in sigmoid patients with sigmoid colon. The leak rate could be reduced from 10% to less than 5%. And there are no, the significance was not statistically significant, but nearly significant in the left-sided colon. And in patients with rectal cancer, the leak rate was slightly reduced, but there was no statistical difference. I think this study showed study is close to the real experience. For rectal cancer, there are many other factors which can contribute to the anastomotic leakage. So, but sigmoid or left colon, the perfusion is most important factor for safe anastomosis. So, I don't use ICG fluorescence imaging for all patients, but sometimes when I consider about the perfusion problem or some patient who has risk factors for perfusion problem, I sometimes check ICG fluorescence for perfusion. And next is lymphatics. Actually, I was more interested in this part. And as you know, colon cancer surgery, as the previous presenter showed, lymph node dissection and CME or CVL is very important for radical resection and patient survival. Also, there are some aberrant lymphatic spread or skin metastasis can happen in colon cancer. So we have to delicately decide where we have to go during the lymph node dissection. Also for rectal cancer, the main vessel is IMA, but some patients has sigmoid lymph node metastasis, or for low rectal cancer, lateral lymph node dissection cannot be skipped. So we have to make exact, accurate decision during the lymph node dissection. So in colorectal cancer lymph node evaluation, we can use ICG fluorescence imaging for regional lymph node dissection plan, or aberrant lymphatic evaluation, or especially for when the cancer is located in intermediate area, or when we do extended lymph node dissection, ICG fluorescence imaging can be very useful. When we use ICG injection, there are two types of injection: peritumoral injection and intravenous injection. For lymphatic drainage evaluation, peritumoral injection is more frequently used. And this, when we inject, ICG enter to the aberrant lymphatic vessel and then show lymph node. And when we use intravenous injection, it is not clear the mechanism, but permeability and retention impact make the lymph node retention, ICG retention in lymph node. So these studies are used peritumoral injection. Most of them use preoperative coloscopy injection of ICG, and we also use preoperative coloscopy injection or for colon, and intraoperative injection for rectum. So peritumoral injection can show lymph flow pattern and sometimes mesocolon margin, and so operation plan can change it about 20% in previous study. And in this case, the tumor was located in the splenic flexure, and I injected ICG preoperatively, and the dose is very small, required to lymph node mapping, 0.75 milligram, less than 1 milligram. And when injected before surgery or 1 day before surgery, we can see lymphatic flow clearly during the surgery. So this is the case. And we injected maybe 3 hours before surgery, and this is the tumor area, and we can easily see which is the main feeding vessel direction. And ICG injection can be remained during the whole operation, so we can check again and again during our surgery. So I followed the left colic artery for this case to regional lymph node dissection. And we evaluated the role of ICG fluorescence imaging for right colon cancer. We used a similar dose of ICG and injected usually the day before surgery. And we could find 70% of skin metastasis in the ICG group. And the harvested lymph node, especially for N3 lymph node, N3 means T3 area, lymph node was significantly higher than conventional group. However, the number of metastatic lymph node was similar. It depends on not only the harvest number, but also mainly depends on the tumor stage. So recently, there is ongoing clinical trial, green light trial, which is evaluate about ICG fluorescence imaging for lymph node mapping, and they showed that they had to change the surgery plan for about half of patients. However, the long-term impact will be published later. And there is a limitation to evaluate lymph node by using ICG, because In the initial stage of metastasis, there is lymphangiogenesis is the main change in the lymph node. So we can see the metastatic lymph nodes like this. However, when the lymph node is occupied nearly fully by the cancer cells, the ICG cannot pass that lymph node. So ICG fluorescent lymph node is not always metastatic lymph node, and ICG cannot always enter the metastatic lymph node. So that is the ICG fluorescence imaging has limitation for lymph node evaluation. Yeah, this is the lymphatic change during the lymph node metastasis. First, lymphangiogenesis is the main, and the late stage lymphatic vessel regression is main changing. So currently there are many ongoing trials to develop targeted fluorescence imaging. This study used bevacizumab conjugated IR dye for tumor evaluation, and they could find very accurate evaluation for by PCR after CCRT. However, these are all ongoing under for phase 1 or 2 trials, so needs many much more evidences to use in the clinic. So in summary, ICG fluorescence imaging is very simple and easy and very cheap, and now the system is commonly used in the field of surgery, so it's may be helpful for beginners or sometimes advanced cases. However, we need more targeting tracers for specific purposes, especially for evaluation metastatic lymph nodes or metastatic disease for patients with advanced cases. Thank you for your attention.
Thank you very much, Professor Park. Any question, please? I know it's a long time, but I have one question. From your research, do you recommend ICG for mapping for the right side colon cancer?
I recommend patients with advanced cases. Sometimes we cannot discriminate metastatic or not, but we have to decide which plan is optimal for that kind of patient. So I recommend not for all patients, but patients for advanced cases.
Okay, thank you very much. So we still have a time. Any question from the floor? Please.
Thank you for your question. And actually, we have to evaluate before cutting before cutting the proximal bowel. Yeah, because after we cut and then ICG check if there is ischemia, we have to cut again. So I think before cutting it is the more optimal for ICG evaluation.
Okay, thank you very much. So I think we close the morning session. Thank you, everybody. Now we will move to the